Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
Welcome to the show. Dr.
Hello.
Mark Vaughn, Dr. Gwen Vaughn, here
me.
for your entertainment and maybe education. We'll find out. Today's show, should we keep it a surprise what today's show is about?
Sure.
I think the title is Your Comments and Questions.
I was going to say, it's a surprise to me.
As it has been many times when just our discussion with people in the chat has turned into actually really good answering of questions that people have or commenting on either stuff that they've experienced personally or interested in or heard on the news or a loved one is going through. And Bianca, we already have chat going. Yeah. Let's bring it up here. We already have Bianca saying hello. Hello, Bianca. We're glad to have you be a part of the show. Welcome to this Monday afternoon or evening, depending on where you may be.
Did our camera move? I feel like I'm
Did the camera
different in frame here. Like it's
that's possible. That could have happened. The straw is really quite prominent.
So much goes into
picture.
Making these shows. We want to make sure we get it perfect.
Yeah, I know. Well, you've got a little bit of headroom.
A little bit. I'm good there.
Did I make myself as tall as you? Is that what I did? Maybe
I'll slouch a little.
Maybe I cut the legs to a chair so that I wouldn't seem so short. Oh my goodness, chat is just blowing up here. We got you guys saying hi to each other. Okay, I'll move on. And of course replying back. And all right, yeah, let's get past all of the greetings here. Greetings to all. Thank you and welcome.
Hello.
All 20 or however many are here at the very start of the show. We appreciate that. Last week we spoke a little bit about finances, healthcare,
right.
Some of the stuff going into supporting primary care, and I think we even made some discoveries about new laws as of the first of the year.
There are some
since that show
went
that
into effect.
There's actually some new Medicare codes for the benefit of primary care, so we are super thankful for that, and we are
especially with the cuts that
and allowing us to use one of the codes, for annual wellness visits that wasn't allowed on those before. Totally appropriate because the money is being, the direction it's going is to those doctors who are taking care of chronic problems over time. The sort of stuff that's been terribly undercompensated in the past.
Right.
And now, because all the money would go to like procedures, if you do a technical procedure with your hands, it pays very well for that procedure, but taking care of the problem that leads to the need for that procedure, like diabetes causing somebody to have their foot amputated or knee or whatever, that wasn't as well compensated, and so you didn't have this incentive to really stay on top of people's control their diabetes or their high blood pressure to keep them from getting disabled and needing additional expensive services. Now we've got a little realignment of, it's important to take care of these things. And to practice good management of chronic illnesses and preventive measures and screenings to keep from having to spend that money for big, expensive items in the future. Okay, we also have, a Happy New Year from Ireland.
Happy New Year.
Jeanette, thank you. We appreciate it. I think Jeanette's commented before the show, so we appreciate that. And yes, the conversation goes on.
Ireland, I had a patient this morning
you were just talking about
that. Sailed from Scotland to Ireland. He was telling me all about it. Said 95 miles total, so I don't know which route he took.
So he didn't take the quickest route.
He said at times it was pretty harrowing. Like he and his crewmates, it was sailing, on the open sea essentially.
Yeah.
But for 90 miles, he said it took like
pretty
8
cool.
nights. It was a pretty neat story.
How long again?
Yeah.
How long?
8 nights, so I'm guessing that would be 9 days. That's what he said. So.
Wow.
Yeah, that's a long time.
I think they went kind of slow, or the wind was against them.
Well, yeah, he said they were fighting it for a couple nights where it was just, like he said, 20-foot swells and I was like, holy cow, that's crazy.
What size boat?
I don't know. I didn't ask, but it fit, I think, almost 8 people. So decent sized boat.
This was on purpose?
I don't. Yeah. He enjoys.
It wasn't a lifeboat
off
of
this wasn't something
cruise ship that went down or something.
No, it's pretty crazy.
What else have we had along the lines of our topic from last week that's come up? We had some new codes that we shared with,
Yeah,
We also
we talked about finances as far as loan repayment. I don't think there's anything new. With the new administration, there may be some changes to that loan repayment. So those of
for
you,
the good or the bad.
that's the question.
It could go either way.
yeah, I really did.
No, really, I can make arguments for either way.
Yeah, with the new administration.
Yeah, plus you've got advisors in the new administration that I've been reading a little bit about the ones when it comes to health-related positions. For example, you can have somebody who's very much promoting vaccination programs and somebody who's just almost completely anti-vax, and they're both having to work within the leadership of the federal government for things related to Medicare or the CDC or Secretary of Health and Human Services. Just all those. It's going to be interesting to see the interplay of the different opinions that come in, because it's not all just one mindset.
No unilateral decisions
being considered
made
for the positions. Yeah. I keep looking for your comments and questions because they are welcome, absolutely welcome. Also as always, looking for a comment from Lindsay Antwine, who quite often is a part of the show. The reason we mention her name is because she is our person on the Patreon, which I can show you right here, the Patreon, what it is. Down at the bottom, it's coming across. There it is.
Hey.
Patreon. Yeah, there it is, Dr. Vaughn. So that's why we always mention Lindsay's name, because of what she does on the Patreon. Oh, we got a comment or question here from Audrey McDonald. Let's see what it is. She says, from Northumberland. I actually, when I do my DNA thing, find that much of it comes from Northumberland, as much from there as from any other part of the world. So interesting that we have a comment from there. Just been diagnosed with cold agglutinin disease.
Oh, yeah.
Have had treatment, now waiting for blood results. Wow, okay.
That's going back.
Non-hematologist. Let's come up with cold agglutinin. Cold agglutinin. There's another word that comes after it, not disease. Cold agglutinin.
Yeah.
You know what I'm thinking of,
I do, but it's not coming to me.
This is referring to a disorder of the blood clotting elements in the blood. And it actually can be affected by temperature. That's why it has the word cold in it.
So when it is cold.
Is it that they get coagulation when it's cold, or?
I believe so. Because, there were two different types of, gosh, this is going way back.
And then I'm not even sure if conventional
very rare disease that we just don't see every day. So
are used for that.
I'd probably have to go.
Yeah, you're pushing us. We appreciate it.
You're probably a better expert on cold agglutinin disease.
Audrey, that's a good one for us. Yeah.
Yeah.
We also have, there's Lindsay. Thank you, Lindsay. You rescued me here. I'm here just depressed about everything, so not feeling like everything. Well, I'm sorry that everything. I mean,
sorry to hear about that.
We still have us, so I can't be depressed about everything.
At least for 30 minutes a week.
You can
put your depression on pause.
You can be depressed about half hours through the rest of the
Oh, man. That sounds so bad. Oh, man, for somebody
we are sorry.
With true depression.
I know, and then we're laughing at her. That's horrible. We hope that somehow we can make a bright spot with our show. We really, and thank you for coming, even though you didn't feel that great. We appreciate that. And of course, you've got people who are, you don't see them, but you do see their comments coming up here, that these people care about what's going on for you and are being friendly. So, and she recognized that. She's thanking them. Good. So that's cold agglutinin. I was saying, we were both talking at the same time, that I wasn't sure if it would be addressed through the either conventional or novel anticoagulants or not.
I don't think so. It's an autoimmune disease, so I'm pretty sure they treat it. She would know better than us, but I'm pretty sure they treat it through those newer, like rituximab, which is Rituxan, and all of those the antibody treatments that we use to treat those newer. And I'm pretty sure that's how they treat it.
Was this somebody from the UK?
I think it was North.
So
I don't know how they.
I'd be really curious to know if NHS pays for.
It's a great question, because those are very expensive medications.
If you're getting these
here in the United States.
These newer, what do they call them, biologics?
They're antibody treatments.
Synthetic antibodies, right?
Yeah.
Monoclonal antibodies, I guess they would be.
Exactly. Yeah.
So that'd be very curious to know. So if you're able to comment in, here we go, Audrey McDonald. Had rituximab.
Okay. Rituxan, yeah. Anything that ends with MAB at the end, that stands for monoclonal antibody. So that's kind of how we know that, those are the
concerned about the
synthetic.
Yeah,
I'm curious if that didn't work, or they had to move on to a different one, or maybe you had it and it's working well. I think usually with those, you need an ongoing course for a certain, sometimes lifelong.
Until you have some kind of remission.
Right.
Hopefully.
Yeah, usually every couple, depending on the medication, every couple months. Some of those medications are self-injection every week.
There's different ways they're administered. And then we also have Bianca saying, I've been watching the fires in LA. It's so sad what's happening. Hope no one else succumbs to the devastation.
Yeah, it is. Top of mind for us. We are nowhere near that, fortunately. However, we know and have family members down there and loved ones, close friends, and it is devastating. I have my brother-in-law is a paramedic firefighter, and he is on the front lines fighting that fire. He was over on the Eaton fire in near the Rose Bowl, and now he's over on the Palisades fire. And it's it is like he sends videos to his wife, and then my sister-in-law sends it to my wife, and she shows me, and it's devastating. Like the what it has done. It is truly horrific. So
and then other family we have down there, thankfully, is
not far, in that area.
Far enough away that we're not really concerned about.
They're far enough away.
But he's in there. Okay, I didn't know that he was down there.
Yeah.
And of course, support for Audrey also from Hilda and
Bristol.
Blood sent to Bristol for detailed. You're testing in Bristol. Okay,
that must be one of the bigger
research center or a tertiary care center in Bristol. We hope for the best with that. That's right. There's so many things like that now that we actually have a treatment for.
Right. It used to be
when I started medical school, this stuff was still it was just hardly even civilized, all that we had available.
Right.
There was so little
pretty amazing
to call upon to treat for these things. It's such an interesting thing we see, these changes in medicine and the technology.
Yeah, the biologics have really revolutionized the way we treat autoimmune disease. Depending on what the disease was, we used to have only a few things at, steroids, or like for cold agglutinin, where it attacks red blood cells, transfusions, just trying to keep your blood cells up when you go through the crises. Yeah. We used to have a very limited set of treatment options, but now, that's expanded.
This whole area of so-called biologics.
And they work so well and very safe. You kind of hear some of you see the list of side effects of things that may happen, but for the most part, these are very safe medications.
Yeah. The horrible side effects that everybody who's ever watched television
they list them out.
Has seen this list or heard it, because these seem to be, for
the
most
ones
part,
you see on television.
Expensive medicines that people either go ahead and pay for or try to get prior authorizations for. Somehow the drug companies get huge amounts of monies for these. And I'm not going to say it's completely inappropriate for it to be an expensive thing, because it's not something that you just pick off of a tree and process and give. It took money to come up with these. Again, I don't want to side with the drug companies. I'm not a fan of them in many respects, but I do recognize that, yes, it takes an investment. There's a reason that these are coming from the countries that they are. It's because they're rich countries and it costs money to make these drugs. It's
to do the research.
I think we've talked about this before. I think very recently, this very difficult situation we're in. Yeah, it was when we were talking about the GLP-1 agonists, where we're scratching our heads, going, "Do we give these, knowing how much they cost and how much resource it takes to be able to give this to the patient to treat?" And you want to treat them, you want to treat the illness. Yeah. And if the patient's right there in front of you, you go ahead and write the prescription. But will the insurance company cover it? And if so, what is it that they're either not covering, or we're going to have to raise premiums for everybody? These are hard questions that very hard to ask when it's just the individual who needs the medicine on that level.
Yeah. I mean,
but then you go in the other room
population
and you're talking to a room full of 30 people who are losing their insurance because it costs too much. That's tough.
Yeah. Yeah, one of the big things that we, as primary care doctors, are trained in is population health, which is kind of an interesting term.
Yeah.
And a lot of the preventive medications that we give are based on population health. So the idea is that we are treating personally, between us, thousands of patients, between all of the primary care doctors in the United States, millions of patients. And we know if you do something enough, you are going to see a benefit. So the big, I guess a good example of that is treating cholesterol. We have these calculators where we can actually calculate your risk of having a heart attack or stroke in the next 10 years. And we know that cholesterol medications called statins are effective at reducing that number and are really effective if we spread that out over thousands or millions of patients.
The ones who have the higher risk for actually having the heart attack or stroke. So you throw it at them, it's going to stick.
Exactly.
Yeah.
So
on a large scale.
When we're talking to a patient and saying, oh, your risk is 15% over the next 10 years, an individual patient, when they're right in front of you, may say, oh, 15, what's that, 1 in 7? That's 1 in 6, 1 in 7.
Chances are I'm not going to have it.
Yeah, that's not huge. It's not a huge amount of risk. However,
but we're doing that to 7 patients a day.
Exactly. Spread that out. We know that if we treat you and those 7 patients, we're going to save one of you from having a heart attack or stroke. So
over 7 years.
Over 10 years.
10 years, I'm sorry. Whatever the study was.
Yeah. So it is an interesting way to look at medicine where we as primary care doctors in the room with a patient need to think of both these things and hold them in tension and have these conversations at the same time while making good decisions for the patient and for the general health of populations. So
we have comments. Look at this. We got
comments.
I can't read the name here. Can you read the name? PMAC says, gents, I'm 74 years old male who on Mounjaro November 1st.
Oh, so fairly new, a couple months here.
The usual effects, but one that concerns me is my pee stream had reduced considerably that first week.
Did you have diabetes?
Oh, well, if he's taking Mounjaro.
Mounjaro is the one for diabetes, because Zepbound is the one that's for weight specifically.
So people with diabetes, they typically will, when their blood sugar is high, have a large volume of urine because all the sugar in the urine is osmotically active and pulls fluid.
So you're peeing more.
In the kidney, pulls fluid into the urine stream. And so that's the first thing that comes to my mind.
That was what I was thinking too. Yeah. If we're
maybe this is a good thing.
Finally getting your diabetes under control. Maybe
we're polyuric because of high
I don't know of
glucose
any
in the urine.
Effect on the prostate of those GLP-1s. I don't know of how that would work.
What if they were both happening at the same time?
And then that's the other thing. Is this something else that just happened coincidentally where you noticed it when you started taking it? So talk to your doctor about that one. We don't give out medical
Bianca's
advice.
on Mounjaro. Been on it since about August. I don't have any side effects though. Very good.
That's fortunate.
Yeah, we're glad for that. And then Audrey, I've
Hopefully
joined
you're
a
having the
research.
side effect of weight loss.
Yeah, hopefully you have that. I've joined research. Well, if they need it.
Or your diabetes is under control. Whatever.
Probably do if they're on it though.
Yeah.
I've joined a research project as it is a rare disease. Yeah,
for the
absolutely.
gluten. Yeah, that's a good idea. So. We want to learn more about that.
And then Ali says, antipsychotics and erectile dysfunction correlation? Yes. No hormones problem?
Most mental health medications
comes with the territory. Sorry about that.
Have erectile dysfunction.
Yes, that's a very known complication. Audrey's telling us I'm lucky to receive everything free. So she's getting the rituximab at no cost to her.
Oh, wow. Because this is
NHS.
In NHS, yeah.
So interesting. So we know that in NHS. For those of you who don't know, National Health Service in Great Britain, it's just covered by the government, is my understanding. That just by
so it would be built
being
into
a citizen,
their taxes.
You're just
how they do it.
You're just taken care of, like having roads to drive on here or a military to defend you here. They have health care there
in the governmental.
So just so interesting, but at the same time, that's a wonderful thing that she's able to get that medicine. Then there's on the other side of it, there's going to be trade-offs for whatever system you're in. And the trade-offs there are, if everything's covered, either you're going to have high taxes to pay for it, and or not have everything available, which is why we're kind of wondering, would Mounjaro be there? Because I understand that some things that we have available here are a little more difficult to get there, and I don't know if it's advanced imaging or
Bianca's in the UK,
techniques.
right? And she just said she was on Mounjaro?
I thought it was Audrey.
No, Audrey's the one that has the cold agglutinin, and her stuff's paid for. But Bianca says she's on Mounjaro. And I'm pretty sure you're in the UK. Correct me if I'm wrong.
Well, Audrey's the one who says I receive everything free.
Yeah. So the Rituxan.
And the Mounjaro too. Bianca's saying,
there you go.
I get my Mounjaro for free NHS.
Yeah, I'm curious.
Interesting.
How they make that work if there are certain restrictions. We have our own restrictions here, mostly imposed by insurances. And financial restrictions from patients if they want to try to pay for it.
I wonder what this whole conversation sounds like from their perspective. We know what it sounds like from our perspective.
Right.
I wonder what it sounds like.
Just sound like
this
really
whole
weird.
insurance thing, and people have different insurances, and the regulators for it are different from state to state.
Oh man, yeah.
It just must look crazy to them.
Those Americans.
I was going to use the word system to say the system that's developed. It's not. It's not a system. It's just this strange interrelationship of different entities. That
right.
System is a very nice term to apply toward it.
Right.
So we have things like the Affordable Care Act that tries to take what's there and make something better out of it. Some people talk in terms of, well, you just got to throw the whole thing away. Let's start over with something new. And you hear that at both extremes.
Right.
You hear that at the extreme right saying, get rid of what you currently have. We're going to do something else. Most likely
free market, probably.
Free market driven, which we do not have free market healthcare right now. People don't know how much things cost before they buy them. They don't shop before they buy them, so that's not a free market. And then at the other extreme, you've got Bernie Sanders with free healthcare for everybody.
Right. I think somebody once told me, and maybe some of our international audience can correct me if I'm wrong, but that America is the only one where your healthcare is typically tied to your job.
Oh, that's a weird thing here too. It's through your
which
employer.
You're probably saying, like, if you're in the UK right now, saying what? I don't get it. So my healthcare is through our office, through where I work, and most people get their healthcare through their work.
So strange.
As a benefit of working there. So if you,
I think I know where it came from though. Have you heard this? That back during World War II, when you weren't allowed to give people raises.
Oh yeah. When there was a freeze on
the way that you could give something to your employees that would be valuable was to give them a benefit like health care or health insurance.
Yeah, that sounds about right.
And that's
about
when
that time.
I think that's about the time that Kaiser started, just
makes sense.
Not paying for somebody else to care for the patients, but actually providing the whole mechanism for the health care, which then turned into
the HMOs.
The HMO Kaiser that we have so big, starting here in Northern California and then spreading
right.
to other parts of the country.
Yeah. Something interesting to think about.
So Bianca says you have to
fit a criteria.
All my meds, hope doesn't change. Oh, no, I'm sorry, I'm reading the fat diabetic got me at. And then Medi-Cal is covering all my meds, hope it doesn't change. That's Hilda. So Hilda has Medi-Cal.
So for those in the other parts of the United States, Medi-Cal is California's version of Medicaid.
Yeah,
that's what it is called.
Well, I think some other states have a unique name for it in their state,
but in California,
that's the California
that's
name for
what it is.
Medicaid.
So
typically, it's going to be somebody who's not necessarily 65 and over. That's Medicare.
Yeah.
Although you can have both. Medicaid is typically somebody low income
in the state or disabled sometimes.
Or disabled.
Certain disabilities go to the
Medi.
Medicare level. So for those of you in an international audience, again, these are our federally government-sponsored programs. So we do have some. Medicare is for 65 and older. Medicaid is for the low income and disabled.
And just to make it more confusing,
it is
Medicare for people over age 65
and
or disabled.
With kidney disease.
And people with kidney disease.
There's a carve out.
And people with kidney disease.
It's such a
We're not joking. This is actually
is true.
really how Medicare is. So Medicare is at the whole country level.
Yep.
And then Medicaid, or in California,
State by
Medi-Cal,
state.
is state by state for people who
And it's run by the state.
can't afford health insurance some other way, and so it's paid for by the state. In this case, when we say state, we mean the individual state.
Yes. Yeah. California,
Yeah.
Oregon, Washington, Utah, etc.
This is just getting laughable.
The more we talk about the United States healthcare system, the more we just shake our heads.
And kidney disease. Weird.
So
weird.
we, because we're in California, have a picture of a single payer that we both see that has been done well and that has been done historically poorly. We
got everything.
For Medicare is actually run fairly well,
Yeah.
and for everybody over 65 who participates in it, everybody has their gripes about it. But it is actually a pretty good system.
Oh, I would take it. I would take it in an instant.
Yeah, absolutely.
That's how good Medicare is. I would do it.
Yeah, and the way it's set up is very good. Now, contrast that with Medi-Cal, which has gone through various iterations, especially since Obamacare came in, and they had these weird, what would you call it? Like I don't even know what you would call it. But it's not done the greatest to the point where they don't reimburse
It's not
independent
funded.
practice.
It would cost
enough
so much to provide
that
the care.
we cannot, we can't even.
So we don't even. We're not part of it.
We can't.
Yeah.
I mean, we enjoy doing what we do and keeping the lights on. So
You work out the math, and here's how it works out. That if the way that we're set up, were to have a Medi-Cal patient come in, you work out the math for how much it pays to see them versus how much it costs, that portion of the electric bill, the rent, the insurance, paying the MA, paying the front desk office. In the end, it's actually negative.
Yeah.
That's how the math would work out. The places that do provide that care are funded through other sources. They've got money
extra.
coming in from outside in addition to that. All right. So
Hey, sorry, little insight into
we
the
actually
healthcare system.
filled in the time quite well there. I think we'll cut off here, but thank you, Dr. Gwen, for
There we go.
a lot of information. Thank you to our viewers.
Now you guys know.
Thank you for sharing with us about your Manjaro in the UK and cold agglutinin in Northumberland.
Northumberland.
Which I'm going to go look that up again. It's in the north. It's like probably borders Scotland, I
Couldn't
guess.
tell
I'm pretty sure it borders Scotland. We'll check. So, very good show, and we look forward to doing this again. I'm not 100% sure there's going to be a show next week because of
You may
scheduling.
not be here. Yeah.
But, every week that we're here, we do the show. All right, so until next time,
Yeah, I'm Dr. Wayne Vaughn.
Dr. Mark Vaughn telling you to stay in good health.
Doctors, thank you for another informative session. Auburn Medical Group is located in Auburn, California, USA. Thank you for participating. Please tell a friend and join us again next week.